My disclosures are here for you. I occasionally lecture for Pfizer in the area of lipids and the area of pain, and I'm a consultant on outcomes research projects for the outcomes research group for Merck. So all the products there are investigational that I've been involved with for the last couple of years. None of those are currently on the market. I'm going to hit some highlights with cardiovascular. This is a cardiovascular-focused meeting, so I'm going to do the cardiovascular stuff. And then at the end, I've also thrown some stuff together on the management of patients with type 2 diabetes based on cardiovascular risk reduction and some of the information there, as well as one or two of the new drugs and some new data on old drugs in diabetes as well, relating mainly to cardiovascular. But Dr. Basil in the last presentation made a comment about the combination of niacin, niaspan plus Simvastatin. And NIH stopped the AIM-HIGH trial, and my understanding is AIM-HIGH is going to be presented later this month at the American Heart Association, and I would imagine it'll be published simultaneously, but I don't know that for sure. November 15th. So just about a week from now, you can see the data from AIM-HIGH. But AIM-HIGH, if I were to ask you, and if you were to have asked me a year ago, do I think AIM-HIGH is going to be a beneficial study? Adding niaspan to Simvastatin, both drugs we have good outcome data with niacin, as Jan mentioned, Dr. Basil mentioned during the last session from the Coronary Drug Project, but it was immediate release crystalline niacin. And if we look at the data that Dr. Brown developed with the HATS trial with a combination of Simvastatin plus over-the-counter sustained release niacin, it looked very impressive. So the rationale was that the combination, we hoped, was going to reduce residual risk in patients already on a baseline of a statin, Simvastatin, an outcome-based statin at 40 milligrams a day. And it was quite surprising to most of us, I believe, that about 3.5 years in, NIH decided to stop the trial because there was no added benefit, and in fact, there appears to be a slight increased risk of stroke in patients who got Simvastatin plus niaspan versus Simvastatin alone. There did not appear to be an incremental benefit of adding another drug to baseline Simvastatin in this trial. Now, the good news is we have a much larger trial underway called Heart Protection Study 2, HPS2, Thrive, that Merck is doing with an investigational compound, Cordaptive. And Cordaptive is Merck's sustained-release niacin added on to Simvastatin, and Cordaptive contains a niacin flush blocker, Rivaroxaban, that's never been marketed before. And it actually binds to the niacin receptors to prevent the flush, unlike aspirin. So it's a different mechanism, and the FDA originally turned that product down because all they had was surrogate data. And the surrogate data was, like niacin, it raises HDL. But after we had our first involvement with the first CETP inhibitor, Pfizer's drug that raised HDL tremendously, but it also increased aldosterone, increased blood pressure, and cardiovascular events went up, not down. The FDA has now required all drugs that raise HDL to have morbidity and mortality data before they're approved. So the CETP inhibitors, and there are several in the pipeline, Merck and Roche both have ones entering phase 3 trials. We've got Cordaptive in a trial with a new formulation of niacin with Rivaroxaban. Those things are still coming. So we'll have data, but right now we don't have data that adding niacin to a statin is beneficial to reduce residual risk based on AIM-HIGH. And one of the other things that I don't know we'll hopefully see November the 15th, it could be there might be a relationship between the stroke risk in this trial and some data from the old Coronary Drug Project. In the CDP trial with immediate release niacin, there appeared to be an increased risk of atrial fibrillation in patients who got niacin in that trial. Now, I haven't seen any data from AIM-HIGH, but is the stroke that was seen in AIM-HIGh when they added it related to AFib or not? I don't know. And hopefully that'll be something that comes out at American Heart. So lots of unanswered information right now, but as mentioned during the last session, the evidence is full dose statins right now. That's where the best outcomes is. Nothing has been added to a statin that has routinely showed additional benefit as far as risk reduction, with a possible exception of a relatively trial that we don't pay much attention to called JELIS in Japan, where they added basically fish oil, omega-3 fatty acids to a statin and had some incremental benefit, but it's a relatively small study. It wasn't full dose of either drug. So really, we don't have good data adding fenofibrate to a statin based on the Accord lipid trial. We don't have good data with niacin plus a statin based on AIM-HI. And the only data we have from the SHARP trial, as Dr. Basil mentioned at the last session, is adding ezetimibe simvastatin in SHARP in those patients with kidney disease was beneficial, but it's not on the basis of baseline statin therapy. So there is no statin comparator in the SHARP trial. And that's the major concern that most of us have about SHARP trial that the FDA has just recommended approval for Vytorin is it's versus placebo. So would we have gotten the same event reduction with a statin alone versus a statin plus ezetimibe Zetia? We really don't know. And that data is forthcoming in the next 1 to 2 years as well with the study that Merck's doing called Improve It. So Improve It will answer the question, Vytorin versus simvastatin alone in patients with acute coronary syndrome. It's much like the Prove It or TIMI-22 trial where BMS compared Prava 40 to Atorva 80 head-to-head and lost, but that's the trial that Merck is doing called Improve It, and it's underway in ACS patients. Don't have the data yet. But those are some of the trials to look forward to in the near future. HPS2 Thrive with simvastatin plus Cordaptive, a niacin-containing, not niaspan, and the Improve It trial with Vytorin versus simvastatin and ACS. So stay tuned, but right now, all the evidence is full-dose statin. So that's kind of where we are. And that brings me to full-dose statin and what's happening here. And the good news is, the end of this month, we will have generic atorvastatin. Lipitor goes off patent the end of this month. There will probably be 2 generics by November the 30th. One is an authorized generic since Pfizer owns a generic company, Greenstone, and the other will be, I believe, Dr. Reddy's. So for 6 months at least, there should probably be 2 generic formulations. At the end of 6 months, there are more than 30 companies sitting at the FDA with generic atorvastatin. So within 6 months, probably by the end of May, the bottom will fall out of the price of atorvastatin in this country. So you can look forward to that, and it is the only statin that has good data at its highest FDA-approved dose of 80 milligrams. So when you're looking for a full-dose potent statin to reduce events, Atorva 80 is where the data is at this point. It was used in the TIMI-22 or the Prove It trial. It was used in Sparkle. Post-stroke, it was used in the TNT trial in people with disease, 10 versus 80 head-to-head. So there's as much data with 80 milligrams as there is with 10 milligrams of Atorva as far as safety and outcomes. So we've got good data on it. And I can tell you right now that Merck is looking at a combination with atorvastatin. Abbott's looking at adding atorvastatin to some of their lipid-lowering drugs, so we may see some combinations with Atorva in the near future as well. But having said that, we have new labeling changes for Simvastatin Zocor. And Simvastatin's been the workhorse statin since it went generic. The price has gone down dramatically, and it has good outcomes. The outcomes are all with the 40 milligram dose. Now, why the SEARCH trial was an interesting study Merck has been doing, and they compared 80 milligrams to 20 milligrams head-to-head in these patients. And when the trial was complete, they did not find a greater significant reduction in events with 80 versus 20. They anticipated a much greater reduction in LDL with 80 than 20 than they actually saw. And if you look at the vascular events, 25.7% on 20 versus 24.5 on 80 at the end of the trial. And that was not statistically significantly different. You can see the confidence interval does cross 1, and the p-value is 0.1. So it did not reach statistical significance. But they also found there was only a 13 milligram per deciliter difference in LDL between 80 and the 20 milligram dose, which was also less than they anticipated in the SEARCH trial. But that's where the outcomes come from. But the reason for the safety concern is the side effects in the SEARCH trial. At the 80 milligram dose versus the 20 milligram dose. 0.9, almost 1% of patients on the 80 milligram dose developed a CK elevation more than 10 times the upper limit of normal, which is when the red flag comes out and you have to stop the drug, versus only 0.02% in the 20 milligram group had a CK above 10 times the upper limit of normal. And then when you look at greater than 40 times the upper limit of normal, it was 22 patients, the 80 milligram, and none in the 20 milligram, and that's what they defined as rhabdo in this study. So their CKs were greater than 40 times the upper limit of normal. So there was a significant increased risk with the higher dose. So that's where the FDA has now said no new starts on 80 milligrams a day. Nobody should be titrated from 40 to 80 who's on 40 today. No new starts at 80. The only people who should stay on 80, according to the new label, are those who have been on 80 for more than a year or more, with no side effects, no drug-drug interactions. They can stay at 80 if they're doing well and been on it for a year or more. Otherwise, no new starts. And the FDA says we'll continue to monitor this, and if we see additional new starts at 80, we'll make the manufacturer discontinue the 80 milligram dose. So that's kind of where we are with that part of it. And you can see the risk is significantly greater with the 80 milligram dose. So based on that data, no new starts, and nobody should be titrated from 40 to 80. But they also changed the drug interaction section substantially. Used to be precautions. Now it's listed as a contraindication. And the drugs that are contraindicated, some of these were not recommended before. Itraconazole sporanox, the systemic azole antifungal, ketoconazole nizoral are major cytochrome P450-3A4 inhibitors and contraindicated with any dose of simvastatin. Posaconazole, another azole, was not listed before it was added. Erythromycin and clarithromycin, Biaxin, major 3A4. Telithromycin ketec, the one and only ketolide we don't use very often. The HIV and also now the hepatitis C protease inhibitors. So this now includes telaprevir and boceprevir in addition to the protease inhibitors for HIV. Nefazodone cerazone, the only antidepressant that's a major 3A4 inhibitor. Gemfibrocil, Lopid, the only fibrate that's contraindicated, and it used to be you could use up to 10 milligrams simvastatin, low-dose Simva with gemfibrocil. Gemfibrocil is not a 3A4 inhibitor. Gemfibrocil inhibits glucuronidation of statins, and it's not just simvastatin and lovastatin, it's also rosuvastatin, it's also everything except fluvastatin Lescol. Every statin, pravastatin, is also glucuronidated. The only statin that doesn't undergo glucuronidation is fluvastatin Lescol. So that's the only one that does not interact at all with gemfibrocil. Cyclosporin, for our transplant patient population, used to be 10 milligrams Simva, it's now contraindicated. Danazol was not there before as a contraindication, was a 10 milligram simvastatin minimum or maximum dose, it's now contraindicated. So those are the changes contraindicated. Maximum dose, amiodarone, cortisone, old was up to 20 milligrams a day, it's now down to 10. So the max dose of simvastatin with amiodarone is 10. The max dose of simvastatin with verapamil and diltiazem are now both 10 milligrams a day. Verapamil used to be up to 20 milligrams of simvastatin, and diltiazem was only added in March of this year, and you used to be able to go to 40 of simvastatin with diltiazem. It's now down to 10. So 10 is the max dose of simvastatin on either the rate-limiting calcium channel blockers or amiodarone. And they've added two new ones that weren't there at all before, 20 milligram max dose with amlodipine Norvasc that was not listed before, and ranolazine Ranexa, the angina drug, was also not listed. It's now max dose of simvastatin is 20 milligrams a day. So those are the new label changes as of June of this year in the label for simvastatin. Package insert, branded generic, doesn't matter. So those are the new recommendations there from the FDA. Just a couple of other things from FDA changes that we haven't thought about. Back in May of this year, or actually March, the FDA added to the label of the proton pump inhibitors, the PPIs, the Nexiums, the omeprazoles, the Prolisex, that whole category of drugs, Hypomagnesemia is a side effect that's been reported with increasing frequency. And if you have low magnesium levels, your patient is at risk for QT prolongation, for seizures, other types of things. So from a cardiovascular standpoint, that's new in the label. PPIs, while they're one of the most commonly prescribed drugs today, we're getting more and more on the adverse event side added to the label. They increase the risk of fractures, including hip fractures. They increase the risk of community-acquired and hospital-acquired pneumonia. They increase the risk of C. difficile, the number one hospital-acquired and nursing home-acquired infection. C. diff significantly increased in patients on PPIs. Hypomagnesemia has been added. B12 deficiency is there with PPIs. And if you're on a PPI, you don't absorb insoluble calcium salts. So calcium carbonate is not your calcium supplement for your patient with osteoporosis who's on calcium and vitamin D. Need to be on a soluble calcium salt to absorb it with any acid suppressor. So like calcium citrate would be preferred over calcium carbonate. And there's also data, again, retrospective data in archives of internal medicine in February of this year that patients on PPIs and bisphosphonates, the alendronate, Fosamax type drugs, don't reduce the risk of fracture. The risk of fracture is increased if they're on a PPI plus a bisphosphonate. Again, it's retrospective data. It's not a controlled trial, but it suggests there might be a problem here in our patients on long-term PPIs. So that's why that's up here. Varenicline safety update. This is something that was interesting that actually we started back in June. The FDA added data to its package insert based on a trial published in Circulation in patients who had pre-existing coronary disease, comparing Varenicline Chantix, the smoking cessation drug, to placebo. It's a study of 700 patients aged 35 to 70 who have documented stable coronary disease other than or in addition to hypertension, diagnosed at least 2 months before screening visit, patients randomized to Chantix, recommended dose, or placebo, followed for 12 weeks, and they continue to follow them, stopping the Chantix or placebo at 12 weeks for the remainder of the year. So a 40-week post-treatment period. And here's the results. When you look at the cardiovascular non-fatal MI, 2% Varenicline, 0.9% placebo, and need for coronary revascularization, 2.3% Varenicline versus 0.9% with placebo. Hospitalization for angina was the same. New diagnosis of peripheral vascular disease or admission for procedure to treat PVD, 1.4 versus 0.9. So the FDA added this to the label saying there is an increased risk of coronary events in people who get Varenicline versus placebo who already have pre-existing heart disease. So this was the original data. This was why it was, but right after that, the Canadian Medical Association Journal published a meta-analysis. And this was 14 double-blind randomized controlled trials in over 8,216 participants. It ranged from 7 to 52 weeks, and what the authors report is the placebo rate was 1.06, in the Varenicline group versus 0.82 in placebo. So that is a 72% relative risk increase. So it sounds really an impressive relative risk increase. But the absolute risk increase is 0.24 of 1%. So your number needed to harm in this case is about 400 patients. For every 400 patients treated with Varenicline versus placebo, there's one more cardiovascular event. And again, it doesn't say whether they were successful or not at quitting smoking. We know that smoking is a major cardiovascular risk factor. So the FDA's position is the benefit still outweighs the risk, but there is some concern with it. And my concern with this meta-analysis is 57% of the weight of the meta-analysis came from the previous trial in Circulation, those 700 patients. So it is weighted based on that data. So the absolute risk increase is about 400 over that year period. So just FYI, you got to put it in perspective. Smoking is still a bad thing. And whatever we can do, there's no medication out there right now that is magic bullet to make our patients quit smoking. We've got nicotine replacement, multiple methods of administration. We have bupropion, and we have Varenicline Chantix, the only nicotine receptor agonist-antagonist, but none of them are benign drugs and none of them are magic. So just we need to be aware this has been added to the label. And just this week, the FDA has also said they've required continuing surveillance by Pfizer for suicidal ideation, increased risk of suicidal ideation in patients on Varenicline. So that's been added again on the FDA website in the last week with Varenicline Chantix. This is also one that may be a little bit of interest because if you go to the American Heart Association, American College of Cardiology, or to the American Psychiatric Association, if you have somebody with cardiovascular disease, there are only 2 antidepressants that are evidence-based and recommended in the guideline. One of those is sertraline Zoloft that's generic, and the other one is citalopram Celexa that's generic. So those are the only 2 antidepressants we have data on. Sertraline comes from SAD-HART in the ENRICH trial, and citalopram comes from the CREATE trial, showing they're safe and effective, and they reduce events in people with history of coronary disease. The last thing you want to do is use an SNRI. You don't want to raise norepinephrine levels in someone with coronary disease because you're going to raise their heart rate, you're going to raise their blood pressure potentially, and cardiovascular events can go up. So SSRIs are the ones we want to use, and the only 2 recommended in the guidelines are these guys. Now, citalopram Celexa used to be FDA approved up to 60 milligrams a day. The new label that came out in August of this year, they've dropped it to a max of 40 milligrams a day because of QT prolongation at the higher dose, including the risk of torsades. So that is the new label change for citalopram. Now, the other thing, if we go look at it, who's at risk? Again, those people with low potassium, low magnesium, other drugs that cause QT prolongation, including some of the calcium channel blockers, especially the rate-limiting channel blockers, macrolide antibiotics, erythromycin, azithromycin, clarithromycin, fluoroquinolones, moxifloxacin, and Avelox. So there are lots of drugs that can cause QT prolongation, and you put them together with citalopram, low magnesium, low potassium, people on thiazide or loop diuretics with low K, low mag, that's where the risk comes in. And the good news is there's no data showing that 60 is a more effective dose than 40. So the guidelines are now max dose of citalopram is 40 milligrams a day, not 60. So that's the new one. And here's that reference for the Heart Association and American Psychiatric Association from Circulation 2008 that recommend sertraline or citalopram as the preferred antidepressants in people with cardiovascular disease, cardiovascular risk factors. So that's where that is. Now, the other thing, if we go look at it, who's at risk? Again, those people with low potassium, low magnesium, other drugs that cause QT prolongation, including some of the calcium channel blockers, especially the rate-limiting channel blockers, macrolide antibiotics, erythromycin, azithromycin, clarithromycin, fluoroquinolones, moxifloxacin, Avelox. So there are lots of drugs that can cause QT prolongation, and you put them together with citalopram, low magnesium, low potassium, people on thiazide or loop diuretics with low K, low mag, that's where the risk comes in. And the good news is there's no data showing that 60 is a more effective dose than 40. So the guidelines are now max dose of citalopram is 40 milligrams a day, not 60. So that's the new one. And here's that reference for the Heart Association and American Psychiatric Association from Circulation 2008 that recommend sertraline or citalopram as the preferred antidepressants in people with cardiovascular disease, cardiovascular risk factors. So that's where that is. And the FDA is requiring GSK to do an ongoing study with ondansetron looking at QT prolongation. So that's also brand new. That was just a little over a month ago. As of yesterday, the FDA announced the final part of the REMS, the new REMS, Risk Evaluation and Mitigation Strategy for rosiglitazone Avandia. And I hope nobody's got any patients on rosiglitazone Avandia. I wouldn't give it to my dog. There are way too many downsides. Well, now if you are, you've only got until November the 17th to register as a prescriber, to register your patient as a patient, and you will have to get the drug through the mail. It will no longer be available commercially through pharmacies. And if you don't register by November the 17th, you're out of luck. So if you've got anybody you know has to stay on the drug, you've got to have them and you registered, or you'll no longer be able to get it in the United States. And I wish it were gone. The downsides for TZDs are the cardiovascular risk is what killed rosiglitazone Avandia, and it's not based on really great data, because there's no study designed to answer the question, does it reduce cardiovascular events in people with coronary disease? We don't have the data and won't. There's no study to answer it. But we do know it increases the risk of fractures. In fact, new data at the ADA back in June of this year from Scotland, 1 out of every 17 hip fractures in the country of Scotland is due to TZDs. 1 out of every 17. They cause decreased bone mineralization and increased fractures across the board, both PIO and ROSI. It's not unique to one versus the other. Probably the leading cause of macular edema in patients with diabetes, TZDs. And if we have any ophthalmologists in the group, I'd be interesting to see if you have seen it, because several ophthalmologists I've talked to said, we didn't realize why we were seeing an increase in macular edema, and it's related to these drugs. It's 2 to 6-fold increased risk. That's now added to the package insert of both pioglitazone actose and rosiglitazone Avandia. And it's worse if you're on TZD with insulin. It goes up dramatically. We also see the weight gain, the edema, the heart failure. The number needed to harm in most of their trials is between 25 and 35 patients over 2 to 3 years for new onset heart failure in the trials with TZDs. We now have a black box of the warning with the pioglitazone of bladder cancer in males. And that was there all along in the rat and mouse model. It's now been seen, and in fact in Germany and France, they have pulled the approval of the drug. Actose pioglitazone is gone in Germany and France due to the cancer risk. And the FDA has said the increased risk in the United States in the label is about 40% relative risk increase of bladder cancer with males taking the drug. It's dose and duration related. If you have a history of bladder cancer, any symptoms, stop the drug, be evaluated for bladder cancer. All those are on the downside. And yet, we don't have good data. These drugs reduce morbidity and mortality after 12 years on the market. So should we be treating people with diabetes with TZDs? I don't think so. Just based on the evidence that's there. So that's new. Moving into a couple of the new drugs. This has been a great year. In the last year, we've had 3 alternatives to Plavix and warfarin marketed in the United States. A new one approved yesterday, I'll tell you about, and show you the data on that. I just updated that last night. The first one's Dabigatran, or Dabigatran, whichever you want to say. I don't mind whichever one. Pradaxa by Boehringer Ingelheim. It's a direct thrombin inhibitor, so it's a new chemical entity we've not had before. And it comes in the U.S. as 150 milligram and a 75 milligram. The United States is the only place in the world there's a 75 milligram dose. Everywhere else in the world, there's a 150 and a 110. And you'll see why there's a 150 and 110 everywhere except the U.S. Because they're the only 2 doses that have been studied. There is no data with 75 anywhere. No study was done at a 75 milligram dose yet. That's what our FDA mandated. We'll come back to that. So it's a direct thrombin inhibitor indicated to reduce the risk of stroke in patients with non-valvular AFib. That's the only indication for the drug right now. 75 and 100. It costs about $250 for 60 capsules, and it's 1 capsule twice a day, either 150 or 75, and it's flat priced. There is no need to monitor the INR, but it does increase the INR, but it does not predict the level of anticoagulation. So there is no routine monitoring of clotting with this drug. It's not reversible with vitamin K, and it may not be reversible with even factor concentrates. It may be dialyzable, but we've got many case reports of people with bleeds that have persisted in spite of all therapies to stop the bleed. So there is no reversal agent for it, and to my knowledge, none in the pipeline for direct thrombin inhibitors. So I'll come back to that. The FDA approval is based on this large trial called the RELY trial. and basically randomized evaluation of long-term anticoagulant therapy in patients who have non-valvular atrial fibrillation, and it's head-to-head with two active arms with dabigatran, 150 twice a day and 110 twice a day, versus adjusted dose warfarin, targeted INRs of 2 to 3. So these are all patients, and the indications are the ones we would normally treat with warfarin. Up till now, warfarin was really the only game in town, or aspirin, and aspirin should be on its way out, because warfarin beat aspirin in every trial we've ever had. So warfarin has been our gold standard to reduce the risk of stroke in patients non-valvular AFib. So the primary outcome objective was to see if dabigatran was non-inferior to warfarin in reducing the composite endpoint of stroke and systemic embolization. And then it also looked at basically bleeding rates. So here's a table I put together with the outcomes. And what I want you to focus on, there's 6,000 patients in the warfarin group, 6,000 in Dabi 110, 6,000 in Dabi 150. So here's your event rate, 1.69% on warfarin, 1.53 on Dabi 110, and 1.11 on Dabi 150, and this one is statistically significantly less than warfarin. And that number needed to treat, it's about basically 0.59 of 1%. So my NNT is 173. For every 173 patients in the overall trial, there's one less stroke or systemic embolization with Dabi 150 versus warfarin adjusted dose. But if you break the warfarin, and they did, break it down based on quartiles of therapeutic time in INR. Remember, our goal was 2 to 3. If they were less than 53% therapeutic, in other words, about half the time they were either above 3 or below 2, outside the range, the rate was 2.2%, significantly higher. If the INR was therapeutic 67% or greater, 2/3 or more of the time, the rate was 1.3 versus 1.1, and that's not statistically different than Dabi 150. So bottom line, to reduce your risk of stroke, which is the primary reason we use these drugs, if the patient you have is on warfarin and doing well, there's no reason to change. If they're not doing well, Dabi's a better option. But it's twice a day, warfarin's once a day. It's about $260 for a month's supply versus about $25 with your INR monitoring with warfarin. So if it's not broke, you don't need to fix it. If it's broken, this is an option, the first option we've had. If you look at major bleeds, 3.86% on warfarin, and again, as you would expect, those who are not well controlled, it's higher. Those who are well controlled, it's lower. Dabi 110 is significantly less than warfarin. Dabi 150 is not significantly different than warfarin overall. And if you're well controlled, warfarin and Dabi 110 are essentially the same. Then if you look at MI risk, it's 0.53 with warfarin, it's 0.74 with Dabi 150, and that's significantly greater. It's actually 0.21% higher, so my number needed harm is 476. So there's actually more MIs with Dabi than warfarin in this trial, and it is statistically significant as reported in the New England Journal. So that's that data. Here's the bleeding data. Under age 75, warfarin 2.4%, and this is extracranial bleeding. Dabi 150 is not different at 1.91, no difference. If they're over 75 or 75 years of age, 3.44 with warfarin, and it's significantly higher with Dabi 150 at 4.68. And this is the reason our friends at the FDA did not approve 110 milligrams, because the bleeding rate is even, so what they did, they came up with 75, but it's not based on any data. It's a retrospective best fit. And intracranial bleeds are significantly less with either dose of Dabi versus, but especially it's significant if they're 75 or older, 1% versus 0.4, and it's actually what we've got is about a 50% reduction, but the numbers are small. They're very small numbers, and one of the things we don't have is there's some other risk factor, intracerebral bleeds, with warfarin, with aspirin, with Dabi, and all these drugs. And one of those is level of blood pressure control. If you look at the data from the Sparkle trial post-stroke, the risk of having a hemorrhagic stroke is significantly higher if they got 80 milligrams of atorva, but it's in patients who had a history of hemorrhagic stroke or they had stage 2 or greater hypertension. So systolics of 160 or greater. Look at the data for aspirin and intracerebral hemorrhage. If your systolic is 145 or greater, based on the MRC trial, and you got their 75 milligram dose of aspirin, 42% relative risk increase in intracerebral bleed on aspirin. So you got to control the blood pressure if you're going to treat these people to reduce the risk of stroke before you fully anticoagulate them, whether it's an antiplatelet drug, whether it's an antithrombotic, it doesn't matter. Control the blood pressure first, especially in these people with AFib, because stroke's what you're trying to prevent. And if you want to prevent a stroke, you also don't want to cause a hemorrhagic stroke as a side effect of your therapy. So blood pressure is important. Compared, there was a lower risk of hemorrhagic stroke, life-threatening bleeds, and intracranial bleeds with or without hemorrhagic stroke with Dabi 110 versus warfarin, and a trend toward lower events with Dabi 150 in those who are less than 75 years of age. Statistically significant fewer GI bleeds with warfarin. Most of the bleeds with dabigatran were GI. And in fact, it's higher GI bleeds than warfarin and lots more GI side effects. And in fact, when you look at side effects, I think I've got it here, 21% a discontinuation rate with Dabi 150, 16% discontinuation rate for warfarin. So that's a number needed to harm of 20 patients. For every 20 patients, one more DC, Dabi, than warfarin, mainly due to GI side effects. Nausea, vomiting, dyspepsia, and GI bleeds were the major reasons people discontinued dabigatran. So it does have more GI side effects. Drug interactions, not major deals. You don't have to worry about 3A4 with it, but P-glycoprotein, if you're on a P-glycoprotein inducer like rifampin, it reduces the levels and should be avoided because it's not going to work. It's going to inhibit the drug from working. P-glycoprotein inhibitors do not require dose adjustment with dabigatran. So those things are okay. So minimal drug interactions. This is the focused update from the American College of Cardiology, American Heart Association as of February 2011. Dabigatran is a useful alternative to warfarin for prevention of stroke, systemic embolization, with paroxysmal or permanent AFib and risk factors for stroke, systemic embolization, who do not have a prosthetic heart valve. So non-valvular AFib, which is where the data is. So they've added it as an alternative to warfarin. Don't say preferred, it's an alternative. So we have two, and we're going to have a third one. Level evidence B, and you can't use it if their creatinine clearance is less than 15 mils per minute. The drug is not approved even at the 75 milligram dose is too much if they're less than 75. 15 to 30, the dose is 75 in the package insert. Greater than 30 creatinine clearance, 150 twice a day, unless they're 75 years of age or older, then it's also 75. So there's an age and renal function dosing with dabigatran. Converting from warfarin, you have to wait until the INR drops below 2, then you start dabigatran at your recommended dose. So you monitor the INR for a couple of days after they've taken their last dose of warfarin. Once it gets below 2 is when you initiate therapy, because it's fast onset. This drug doesn't take a week to work like warfarin does. And if you're switching the other way, you have somebody who's been on dabigatran, didn't tolerate it, got to go back to warfarin. That's a little more different and difficult because warfarin doesn't work right away. So when you convert from Dabi to warfarin, if your creatinine clearance is greater than 50, start warfarin for 3 days before you stop dabigatran. So you overlap for 3 days. If your creatinine is 31 to 50, overlap for 2 days. And if it's less than 30 but greater than 15, you overlap for only 1 day. So use them together because, again, warfarin takes time to work where dabigatran's faster onset. So those are in the label, the FDA approved dosing when you're switching from one to another. The dosing, as long as your creatinine clearance is greater than 30 and the patient is not 75 years of age or older, it's 150 twice a day. It's fixed dose. If your creatinine clearance is 15 to 30 or you're 75 or older, the dose is 75 twice a day. But there is no data on 75. Not a single study has used 75 milligram dose. The data we have in the RELY was 110. and that's what's available in the rest of the world. We're the only country with a 75 milligram dose. They have to swallow the capsules whole. You cannot open and sprinkle. They're capsules, but you can't open and sprinkle it. You alter the bioavailability, not going to get the same effect. And the capsules are not stable when exposed to room air. You cannot take the capsule out of the bottle it comes in and put it in your pill box. And most of us, I do it every day. I put my pills out a week at a time, and I leave them in a pill box. And it's not adequately controlled, and you will lose potency of the drug. So they say you have to keep it in the bottle, and it's only good for now up to 60 days after it's opened. And that cap has a desiccant built into the cap. So when you take it off, you allow moisture in, that desiccant hopefully will take it out, and it's good for up to 60 days now. It was originally 30, it's now 60. And it also comes in blister packs, and then it's good until the expiration date as long as you don't open the blister. So it has to be maintained in that environment, and it can't be sprinkled. Okay? So those are important things to keep in mind with the drug. So that's Dabigatran Pradaxa, and it's being studied for other indications. Direct thrombin inhibitor, currently only for non-valvular AFib, and it's a good alternative in patients who we have problems keeping their INR therapeutic, but again, if you don't take it, it doesn't work, and it's twice a day, not once a day. So all the data is BID with it. The next one is Rivaroxaban, Xarelto, and this one was approved earlier this year. It's an anti-10A inhibitor, so this affects activated factor 10A. And basically, it is developed by Bayer, but in the U.S. it's marketed by Janssen Pharmaceuticals. And it was originally only approved until yesterday for patients who had elective hip or knee replacement surgery to prevent DVT post-hip or knee surgery. And I'll show you the data. But as of yesterday, it's also now approved for non-valvular AFib, same indication as Dabigatran. Okay, so we now have a third option for our patients. So this one's got a half-life of 9 to 12 hours, and the good news for both these indications, it's dosed once a day, not twice a day. So this is QD dosing. And again, there is no antidote to it, but there is one in development. At the European Society of Cardiology meeting this year, there was a 10A inhibitor anecdote presented, so that it looks promising. We may have an antidote down the road for the 10A inhibitors, but not for the direct thrombin inhibitors right now. It is metabolized by 3A4. We'll come back to that. In July, they approved it basically for DVT prophylaxis and PE prophylaxis in people undergoing hip and knee replacement surgery. And it's a 10 milligram dose taken once a day without regard to meals. Morning or eve doesn't appear to matter at the 10 milligram dose. And this is going to be interesting when I give you the new indication. At least 6 to 10 hours post-op. And it was compared head-to-head to enoxaparin in all the studies I'm going to show you. So it's got 4 pivotal trials to get it approved for this indication. And for hips, the duration is 35 days. For knee surgery, it's 12 days. So you take it once a day for 35 days post-hip surgery, once a day early for 12 days post-knee replacement surgery. That's the approved dosing for it. And the trials are the record 1 and 2 for hip, 3 and 4 for knee. So the record trials, and there's 4 of them. And basically it's more than 12,000 patients. Rivaroxaban 10 versus enoxaparin, which has become the gold standard, low molecular weight heparin, for hip and knee replacement surgery. Okay? Results. Here's the record 1 hip surgery. The Rivaroxaban 1.1% had a DVT or PE post-op versus 3.9% with enoxaparin, and that's a 71% relative risk reduction. Number need treat of 36 patients. For every 36 patients treated for 35 days, 1 less DVT or PE. In record 2, the other hip trial, 2% versus 8.4%, number need treat 16. Those are great numbers, and it's less expensive. It's once a day, it's oral, it's not a sub-Q injection. No downside, and I'll show you the bleeding risk in a minute. Record 3 for knee, 9.7 versus 18.8. Number need treat 11 in the record 3 trial. And in record 4, 6.9 versus 10.2 or 10.1%, number to treat 32. Great numbers again, oral once a day versus enoxaparin. Other indications, I'll come back to Rocket. It's being looked at for VTE treatment. It's approved for that in Europe, not in the US. Magellan for VTE prevention, prophylaxis, hospitalized patients, not approved, but being studied. And Atlas, acute coronary syndrome, like Plavix and Ticagrelor, Brilinta, it's got data coming for that as well. Box warning, spinal analgesia, spinal hematoma, just like it's there with enoxaparins, like it's there with regular heparin, it's going to be there with this drug as well. So you have to be careful in that regard. So that's the box warning. Avoid co-administration with strong 3A4 and P-glycoprotein inhibitors, not recommended with ketoconazole, which is Nizoral, itraconazole, Sporanox. The protease inhibitors increase Rivaroxaban exposure, levels go up, increased risk of bleeds, so you don't want to use it. They have the other clarithromycin and erythromycin, which are modest 3A4 inhibitors, modest P-glycoprotein inhibitors. Doesn't appear to change the kinetics of the drug. So says you don't need to worry about it with those, just the strong 3A4 inhibitors. If they have any degree of renal impairment, you've got to watch it, and even the modest 3A4 inhibitors may increase your risk of bleeding. So you need to adjust that as well. Drugs that are combined 3A4 P-glycoprotein inducers, consider, they say increasing the dose, but don't tell you what the dose is. But right now, until yesterday, 10 milligrams is the only FDA approved dose. As of yesterday, there's also a 15 and a 20 milligram dose of Rivaroxaban, Xarelto. So we're going to have 3 doses. Avoid it with severe renal impairment. Creatinine clearance less than 30, it's not recommended. Dabigatran less than 15, not recommended. Hepatotoxicity potential, so avoid the use in moderate severe liver dysfunction. No antidote, and high plasma protein binding means it's not likely to be dialyzable. Dabigatran's dialyzable. This one does not appear to be dialyzable. Here's the bleeding data from the record trials. And Xarelto 10 versus enoxaparin, major bleeding event, 0.3% versus 0.2%, no major difference. Fatal bleeding, no major differences. Bleeding in critical organ, no differences. Bleeding required reoperation, no major differences. So overall, no major differences in bleeding at all. 5.8 versus 5.6% versus enoxaparin head-to-head. So no major concerns there. Here is the other side effects. Wound secretion. Again, these are not statistically different. They all appear to be very similar, and no major concerns over what we've already seen. This is the new indication approved yesterday, and this is the data published in New England Journal earlier this year called the Rocket AFib trial, Rocket AF trial. And this is 20 or 15 milligrams depending on creatinine clearance. They got 20 milligrams unless their creatinine clearance was less than 50, and if it was between 30 and 49, they got 15 in the trial. Hence, the FDA has approved a 15 and 20 milligram dose for this indication as of yesterday. Patients moderate high risk with non-valvular AFib, and the composite CHADS-2 score, the mean was 3.5, and about half had CHAD-2 scores over 4. So these are probably a little higher risk than what we saw in the RELY trial. But again, not a fair comparison. We don't really have any way to compare them. Median follow-up was about 2 years. Warfarin group, this was a concern to the FDA. Only 55% of patients maintained a therapeutic INR. So they had less time therapeutic in this trial as compared to most of the patients in the RELY trial. In the RELY trial, it was in the 65% range. This is 55%. And it's one of the reasons the FDA was originally recommending against approving it for this indication, because the control group with warfarin was not treated as well as they had hoped. But on September the 9th, the advisory committee met and voted 9-2 to recommend approval. And yesterday, the FDA acted on that recommendation and approved the drug for this indication. And I'll show you the data. This is the Rocket AF data, New England Journal. I don't have it broken down like I did with RELY because all the data is not out yet. But if you look at the primary composite endpoint, it was designed as a non-inferiority trial. They wanted to first prove no difference between Rivaroxaban and warfarin. And it met that, and in fact, Rivaroxaban is significantly better than warfarin intent to treat non-inferiority with a number needed to treat of 222. And it was 173 with Dabigatran versus warfarin overall in the RELY trial. So not a major difference. Primary endpoint on treatment superiority, it was also superior on treatment, but not intent to treat. Intent to treat superiority was not significantly different. The trend is in the right direction, but it's not statistically significant. So at this point in time, it looks like it's non-inferior to warfarin. Vascular death, stroke, and embolism is significantly better with Rivaroxaban versus, and my number needed to treat here is 193. So again, we've got a good alternative to warfarin. Hemorrhagic stroke is about half, but you can see the number needed to treat is 556. You cut it by about half, it's 41% lower, and it's significant. Ischemic stroke is not significantly different, but it's not increased, and unknown stroke is not significantly different either. If we look at major and non-major bleeding, 14.9 versus 14.52, no difference. Major bleed, no significant difference there again. Greater than 2 gram drop in hemoglobin drop, it is number needed to harm. It's greater with Rivaroxaban than warfarin. Number needed to harm is 197. Transfusions greater with Rivaroxaban than with warfarin. Number needed to harm is 304. Critical organ bleeding is in the opposite direction. It's significant, 31% lower with Rivaroxaban versus warfarin. Number needed to treat, 278. Bleeding causing death is significant as well in favor of Rivaroxaban, but the absolute difference is 0.24 of 1%. Number needed to treat is 455. And intracranial bleeding is also less, Rivaroxaban versus warfarin. Number needed to treat, 400. So we've got a third alternative for patients non-valvular AFib. This is once a day oral, and I don't know how the 15 and 20 are going to be priced, but if they're priced the same as the 10 milligram, it's about $8 a day. So we're looking at about $240 for a month's supply of the 10 milligram. Hopefully that'll be how the 15 and 20 is priced, but don't know. So it is now FDA approved, and if we look at the approved dosing, for patients' creatinine clearance greater than 50, it's 20 milligrams once a day with the evening meal. This is different. They don't say that with the 10 milligram dose for DVT prophylaxis hip and knee. They say you can take it without regard to food any time of the day. For the 15 and 20 milligram, they say with the evening meal because the bioavailability is increased with food and with the evening meal. So it specifically says in the label for the 20 and 15 milligram tabs only with the evening meal. Creatinine clearance 15 to 50, it's 15 milligrams once a day with the evening meal. Avoid use less than creatinine clearance of 15, and it's got a box warning. And the box warning is, do not abruptly discontinue the drug. Because in the study, when they stopped the Rivaroxaban group, over the first 28 days after they stopped taking the drug, they had 22 strokes versus 6 in the warfarin arm when they stopped it. So they're recommending if you need to stop the drug, you need to switch into another antithrombotic before you stop it. And they don't tell you how to do that. But that's the rationale and why the box warning is there, to make sure patients do not abruptly discontinue Rivaroxaban, because that has a significant increased risk of stroke in the first 4 weeks if they abruptly stop the drug in the ROCKET-AF trial. So that's why that box warning is there. And that's not there for the DVT prophylaxis. This is a new warning. So that's the new data on Rivaroxaban from the ROCKET-AF trial. And in Europe, it's also approved or recommended for DVT and PE treatment that we don't have yet in the U.S. Studies are underway. It's also approved for AFib, and it's approved for DVT prophylaxis for hip and knee surgery. So Europeans have 3 approved indications now. We have 2 as of yesterday. Questions on Rivaroxaban, Xarelto? Yeah. At this point, the question is there a dosing recommendation for elderly? No. They did not find, and again, they haven't presented the data like we have the RELY trial. We haven't got that data mining to see if there was a difference. But nobody said anything about it, and I would assume the FDA would have been proactive like they were with Dabigatran to say, we are not going to approve the 110, we're going to go to 75, even though there's no data on it. Ticagrelor Brilinta is a new drug alternative to Plavix. And this one's approved for acute coronary syndrome in a head-to-head style trial, the Plato trial versus clopidogrel Plavix. So this one is a reversible inhibitor of platelets, whereas clopidogrel Plavix is irreversible. So Ticagrelor is in the same family, but it's reversible, so it's got a slightly different generic name. Comes as a 90 milligram tablet by AstraZeneca, and there's a 180 milligram loading dose, followed by 90 milligrams dosing thereafter, BID. So it's also a BID drug. It's $220 essentially for a month's supply. The parent compound and its active metabolite irreversibly interact with the platelet at the same site as clopidogrel Plavix, the P2Y12 ADP receptor, to prevent platelet activation. So same mechanism as clopidogrel Plavix, no reason to use them together. Would not use Plavix and this drug. This drug actually is significantly faster onset, more effective than Plavix, and gets out faster than Plavix does as well. In fact, I think I've got, this shows you the 180 milligram loading dose, and this is percent platelet inhibition, ADP, and you can see much higher platelet inhibition more quickly within 1 to 2 hours with Ticagrelor's loading dose of 180 versus Plavix loading dose of 600, less and never gets to the same level. So it's faster onset, more complete inhibition of platelet aggregation, and it's also faster offset. This one's reversible, clopidogrel's irreversible. So it's a 3A4 is a major enzyme responsible for metabolism, so we've got some drug interactions. And it also is affected by P-glycoprotein to some degree. Its half-life is 7 hours and 9 hours for the active metabolite. All the studies have dosed it BID. The mean bioavailability is about 36%, can be taken with or without food, and no effects as far as renal adjustment, age, those kind of things that we know about with this one at this point in time. The effect on other drugs, strong 3A4 inhibitors are not recommended, so your drugs for HIV, HCV, clarithromycin, nifazodone, itraconazole, ketoconazole, nalfinavir, and telithromycin, voriconazole, not recommended. Moderate 3A4 inhibitors, DILT and verapamil, do not require a dose adjustment, and 3A4 inducers substantially reduce it and are not recommended either. So major 3A4 inhibitors or inducers are the concern with this drug. It is a 3A4 substrate. Other meds, Simvastatin, more than 40 milligrams a day, increased risk. Well, it's not on the list, and 40 is the max dose now we're using Simva anyway. Monitor DIG levels because you can change P-glycoprotein. Good news is we're not using a lot of DIG today, but this drug can affect DIG. Aspirin, major concern, and we'll come back to this in a minute. The max dose of aspirin with clopidogrel is no max. The max dose of aspirin with Ticagrelor is no more than 100 milligrams, so 81 is your dose. If you're going to use it in combination, which was used in all the trials, like with Plavix and aspirin, this one is with aspirin, but the max dose is 81 milligrams for most of us in this country. So the Plato trial, New England Journal 2009. So this one took a little while to get approved by the FDA because of some of the data. And randomized study comparing Ticagrelor 180 loading dose followed by 90 twice a day to clopidogrel 300 milligram loading dose, which most of us have now moved to 600 with 75 once a day, both in combination with aspirin. 75 to 100 once a day, but higher doses were allowed per investigator. And that's what got us into trouble with some of the data. In the US, more than half the patients were on 325 or higher. And that's going to come back, that actually came back to bite the manufacturer. Patients were treated for at least 6 months and follow-up for about 12 months. Randomly, most of them were male, Caucasians. 43% were greater than 65, 15% greater than 75, and the primary endpoint was composite of first cardiovascular death, non-fatal MI excluding silent MI, or a non-fatal stroke. And then individual endpoints is secondary. Mean exposure was less than a year, 277 days. Here's the endpoints. Primary composite endpoint, Ticagrelor 9.8%, Plavix 11.7%. It is statistically significant. 16% relative risk reduction. My number to treat is 53. For every 53 patients treated with Ticagrelor twice a day, it's one less of those composite endpoints than clopidogrel 75 once a day. Cardiovascular death is also statistically significant, 21%. Number to treat, 91. MI, 91. Stroke, no significant difference. All-cause mortality, number to treat, 72. And in-stent thrombosis is also significantly reduced from number to treat of 167. So most of the benefits are seen with Ticagrelor versus clopidogrel. No significant bleeding rate, 11.6 versus 11.2. So it did have a higher rate of major bleeding not related to bypass grafting, 4.5 versus 3.8, number needed harm of 143. And they did a genetic sub-study because we remember that clopidogrel Plavix is metabolized by 2C19. And we've had a concern that people who have a defect in that enzyme, it doesn't work, and it might increase their risk. So they looked at that with this drug, and there is no genotype that appears not to activate the drug. So this drug worked even in people who had the 2C19 deficiency. So it was not affected by the 2C19 genotype. This is the data with aspirin. And if you look at the non-US, it's still there, but the numbers are very small if you look at aspirin dose. So this is greater than 300. It was only 140 patients total in the non-US arms and 140 with clopidogrel that had doses greater than 300. In the US, 324 and 352 were on greater than 300 milligrams a day. So that was actually the number one dose in the US. They added high-dose aspirin. So it was more than half. And that's where there is no benefit. In fact, the risk, clopidogrel might be better. But when you come down and look at the aspirin dose in the US less than or equal to 100, you're down here, it's on the right side, and overall, when you weight it, it's beneficial. So that's why the FDA has only approved this drug in combination with aspirin up to a max of 100 milligrams a day. No 325. And there's not good data that 325 beats 100 or 81 anyway. Here's the side effect, and the one side effect that's unique and we don't really know a lot about is this dyspnea. 13.8% with Ticagrelor versus 7.8% with clopidogrel, almost twice the risk. But it tends to be transient, and they've done pulmonary function studies, no involvement in pulmonary function tests they've seen. We don't really know why it's there, and it tends to be transient, self-limiting. So there's more data to come, but they've actually done a sub-study of the Plato trial in those with dyspnea and did pulmonary function studies, did not see a change in PFTs related to the drug. So that's not been a major concern, but you can see the includes dyspnea and the like are down here at the bottom. Otherwise, the side effects are pretty similar between the two drugs. No major things, except dyspnea is the only one that sticks out like a sore thumb. And you can see it's mild to moderate intensity, often resolved with continued treatment, and it's not a reason to stop the drug unless the patient does not tolerate it. Uric acid levels tend to go up by about 0.6 of a milligram per deciliter, so it does raise uric acid, and it also can increase serum creatinine. 7.4% had a greater than 50% increase in serum creatinine level over baseline versus 5.9% on clopidogrel. And they didn't progress with ongoing treatment, didn't continue to go up. Often decreased, went back to baseline over time. So we're not sure what's going on there. The box warning for bleeding risk, and as you would expect, aspirin dose is one of the reasons for that. You've got to watch that. And we're using the combination, Ticagrelor plus aspirin is the indication for acute coronary syndrome. And we don't have data for this drug for any other indication right now. ACS is the only indication. We got lots of other indications for clopidogrel Plavix, not yet for this one. Dosage, 180, 2 tabs to start as loading dose, followed by 90 twice a day, with or without food. and you can use a 325 loading dose of aspirin when you're starting it, but after that, 81 is your dose, typically 81. And cost is about $220 for a month's supply of Ticagrelor or Brilinta. So another alternative to Plavix for acute coronary syndrome. So you now have Pressagel Effient, you've got this one as well. So we got 3 options for these patients as well right now. Questions on Brilinta, Ticagrelor? Those are the 3 good anticoagulants that we've got good data on. In the next year, we may have a third one, or another one, second anti-10A inhibitor, Apixaban, has been recommended for approval as well. So we'll see. Got data post-stroke for non-valvular AFib with it as well. Actually, next year, 2012, Plavix will finally go generic for real. And the price will come down quickly, and I wish we had better head-to-heads to really look at it. But I think once it happens, we'll see a lot of people will probably still stay on Plavix because the cost will be a significant driver. And if you're doing well on it again, can't say you need to be switched when the cost is going to be a driver. This is a drug that is available but may not be available a whole lot longer. This one, in my mind, is on the endangered species list. And this is dronedarone Multac. We had lots of high hopes for this drug, an oral antiarrhythmic in the same family as amiodarone, cortisone, for patients with atrial fibrillation or atrial flutter for rhythm control, not rate control. It's an alternative to amiodarone that does not contain an iodine moiety in it, and it appeared to be safer. So it's FDA approved for patients with paroxysmal persistent AFib or flutter, but you can't use it if they have permanent AFib, and you can't use it if you have heart failure. So it's got some major drawbacks for people with AFib because there are a lot of those folks out there. A lot of people with heart failure have atrial fibrillation. Now I'll show you the data because this drug kills people. Okay? And that's why it's got a box warning. The dose is 400 milligrams twice a day, and it costs about $300 for a month's supply. The study that got it approved was the Athena trial, double-blind, randomized, placebo-controlled trial in over 4,600 patients with a history of AFib or atrial flutter who were in sinus rhythm or be converted. And basically was to determine whether dronedarone could delay death from any cause or hospitalization for cardiovascular reasons. So they followed them. Mean treatment was median 22 months and 2,300 on dronedarone, 2,327 on placebo. And you can see the other drugs that were on are recommended. New England Journal, 2009, Athena. The results, median follow-up 22 months. Cardiovascular hospitalization or death from any cause, 39.2% placebo, 31.6% dronedarone, number to treat 14. But what drove that endpoint? It's not death. Underneath it, they pre-specified they report the cardiovascular hospitalizations, what drove it. 36.8% placebo, 29.1% dronedarone. Death from any cause, no difference, 2.4, 2.5. So the FDA approved indication is to reduce cardiovascular hospitalizations, not the combined endpoint, death in cardiovascular hospitalizations. And that's what's reported in New England Journal. But the FDA did not allow them to make the claim because it didn't reduce death. Okay? So it's only to reduce cardiovascular hospitalizations. The Andromeda study is what got him into trouble the first time. This is heart failure patients. And heart failure is a major cause of atrial fibrillation. So these are people recently hospitalized with symptomatic heart failure and severe left ventricular systolic dysfunction to Multac or placebo. They enrolled 627 of the 1,000 intended patients and stopped the trial at 63 days. 63 days after the trial started, it was stopped because mortality. 25 patients dronedarone group died versus basically 8.1% versus 3.8% in placebo. So the death rate went up, and your number needed to die here is 26 patients. For every 26 patients treated for 63 days, there's one more death. Okay? That's why the trial was stopped and why it has a box warning and why the FDA required the company to advertise in the cardiology literature, including the Journal of the American College of Cardiology, you can't use this drug in people with heart failure. Amiodarone can be used in heart failure. This one cannot. So it's contraindicated in heart failure based on this data. So there's the box warning. So contraindicated in class 4 or class 2 to 3 with a recent decompensation requiring hospitalization or referral to a heart failure clinic. Contraindicated or second and third degree AV block because it does have beta blocking activity like amiodarone does. It's additive to lower your heart rate. Concomitant use of strong 3A4 inhibitors are contraindication. It's metabolized by 3A4. And concomitant use of drugs that cause QT, can't use it either because it, like amiodarone, causes QT prolongation, increased risk of torsades. So that's the box warning and the contraindications for the drug. They did another trial that's not been published. It was presented only, Dionysus. And here they compared dronedarone head-to-head to amiodarone. And the primary outcome was to look at duration of normal sinus rhythm. And after 7 months of follow-up, 73.9% in the dronedarone arm had gone back into AFib versus 55% in the amiodarone arm. So it's not as effective as amiodarone keeping a normal sinus rhythm, but it's better tolerated. Side effects, with the exception of GI, were better with dronedarone than amiodarone. So that's the Dionysus, again, not published. Well, in January of this year, the FDA added a liver safety update to their label because of reports of hepatotoxicity with the drug. So that was added in January. In February, it was on the FDA drug watch list for interactions with warfarin. When it first came out, it said no drug interactions with warfarin. Amiodarone interacts with warfarin all over the place. This one supposedly does not. Well, since the drug's been on the market, lots of INRs have gone up in people on warfarin and dronedarone. So the FDA is making them do additional work there. In fact, this drug has shown up 5 times in a row on the FDA drug watch list. No other drug in the history of this country has shown up 5 times on the list. The last 5 times this drug has shown up on the FDA watch list. So this guy's on the endangered species list. Drug interactions already talked about. Well, the American College of Cardiology, American Heart Association, focused update, give us the information, and one of the things that's new this year is rate control. Based on the RACE-2 data, we used to say we wanted to get the heart rate less than 80 in people with AFib with a beta blocker. The RACE-2 trial compared less than 180 to less than 110, no difference. So now they give it level of evidence B, new recommendation, based on the RACE-2 trial, less than 110 is not an inferior to strict rate control less than 80. So we don't need to crank up the beta blocker dose to keep the heart rate less than 80, less than 110 is in the new guideline. So that's new this year. Also, we have data from dronedarone. Dronedarone is reasonable to decrease the need for hospitalization in cardiovascular events in patients with paroxysmal AFib or after conversion of persistent AFib can be initiated during outpatient therapy, level evidence B. It's an alternative for these patients. And harm should not be administered to patients class 4 heart failure, patients episode or decompensated in the past 4 weeks, or have depressed left ventricular function, left ventricular ejection fraction less than 35 or equal to 35%. That's also in the focus update. So they've acknowledged that data. What they haven't acknowledged is the new stuff. New safety concern July of this year. Study that was being done that was also stopped early called the PALLAS trial, P-A-L-L-A-S, begun a year ago. About 10,000 patients with permanent AFib were being studied in the trial. So these are permanent AFib patients. And here's the data. And this is at 1 year, cardiovascular death, MI, stroke, systemic embolization, 2% Multec, 0.9% placebo, so it's worse, and its statistically significant number needed to harm is 91. Death, unplanned cardiovascular hospitalization, 7.5% versus 5.1% placebo, number needed to harm, 42. Stroke, number needed to harm, 143. Heart failure hospitalization, number needed to harm, 84. Nothing in the right direction, all in the wrong direction. Stop the trial. So now, if you got permanent AFib, this is not your drug either. So it's contraindicated in heart failure, contraindicated in permanent AFib. So why do you want to use the drug? And it's $300 a month. And the only data it has is paroxysmal AFib reducing cardiovascular hospitalizations with lots of downsides. So I think this drug's on the endangered species list. The European Union Medicines Agency recommends restricting the use of dronedarone. So it's the first step in limiting its access in Europe. So again, it's moving in that direction. And like I said, 5 times in a row, the FDA's put it on its watch list. Pitavastatin, Livalo, the newest statin by Cowa and Lilly. No data, no studies to look at morbidity and mortality. To my knowledge, none to come. The 1, 2, and 4 milligram dose is how it comes. And 4 milligram gives you about a 40% reduction in LDL. About the same as 40 of Simba, about the same as 10 of Atorva, about the same as 5 to 10 of Rasuva, as far as LDL reduction. And here's your LDL reduction. The 4 milligram dose, LDL 44%, Simba 43%, so very similar. And side effects, again, very similar among them. And if you look at the triglyceride effects, they're very similar, not tremendous in any of these. The HDL effects, not significantly different. So it's another statin, but it has no morbidity and mortality data. It's got a branded price tag. So why would you want to use it? I can't think of a reason to use it. Drug interactions, it does interact with cyclosporin, rifampin, erythromycin, gemfibrocil, the protease inhibitors, but it's not a 3A4 substrate. It's P-glycoprotein or OTEP proteins, and it costs $120 a month. When you can get pravastatin, lovastatin, simvastatin, and hopefully soon to be atorvastatin at generic prices. No reason to go above, to pay more if you don't have to. So I think this one's not got anything to add. Azlosartan, Adarbi, the newest ARB by Takeda. FDA approved for hypertension alone or in combination with other agents. No outcome data, so it's not going to be a compelling indication based on evidence, but it does look like it's structure related to candesartan. It's a prodrug, and it's rapidly hydrolyzed to azlosartan in the GI tract. Half-life's about 11 hours, and it costs about $86 for a month's supply of the 40 and 80 milligram, and the usual dose is 80 milligrams once a day with or without food. If we look at the blood pressure data, it looks pretty good comparing it to olmesartan, Benicar, and valsartan Diovan, and they use the Diovan 320 max FDA approved dose. So clinic blood pressures minus 9.5 over minus 4.4 baseline with clinic blood pressure mean baselines are up here at the top. And Adarbi 80 minus 14.9 minus 7.5. So it looks like it's got a slightly greater blood pressure reduction, and also then Benicar, olmesartan, and in study 2 the same thing. So we've got pretty good blood pressure reduction with this drug, and I wish we had morbidity and mortality data. The exciting thing is, in the pipeline, they have the combination with chlorothalidone. So it will be the only ARB or ACE that has a fixed combination with chlorothalidone, which is one of the 2 evidence-based diuretics that I would recommend for hypertension. Chlorothalidone and indapamide are my go-to thiazide-related diuretics based on evidence. So this is actually the American Society of Hypertension has recommended to the industry they consider chlorothalidone combinations with their drugs, not hydrochlorothiazide. So they've actually made a recommendation. This is the first drug that's going to have that of the new categories. Because there's one that I wouldn't give to my dog that has it already, and that's tenoritic. Atenolol, tenoramine, is not a once-a-day antihypertensive, but its combination is with chlorothalidone. That's not my drug. And here's your change in systolic blood pressure when you add it to chlorothalidone, and you can see in clinic or 24-hour mean blood pressure reductions, you're looking at azlosartan, chlorothalidone, 40-25 or 80-25 in excess of 40 millimeter drop with the combination with chlorothalidone, and olmesartan with HCTZ about a 37. So again, significantly greater drop, and this one will be the first ACE or ARB combination with chlorothalidone fixed combo. And that leads me into, and I think Dr. Basil talked a little bit about this, this is a new UK NICE guideline. This may or may not give us a glimpse of what we're going to get from JNC 8. This was published in August of this year, and it's evidence-based, and they're suggesting clinic blood pressure is 140/90 or higher. They are recommending something that's radical. And Dr. Basil and I mentioned just before this, he doesn't think JNC 8 is going to go here because of the cost, but they're recommending 24-hour ambulatory blood pressure monitoring upon diagnosis in the UK. And their guidelines, the full report they've done a cost-effectiveness analysis, they believe it's cost-effective. And that's included in this report. But they're recommending ABPM to confirm the diagnosis. So you can catch white coat hypertension. You can also look for dippers versus non-dippers, 24-hour control, those who raise their blood pressure at night. And what they're suggesting is at least 2 measurements per hour during the waking hours, at least 14 measurements to confirm diagnosis. And in the office, home blood pressure monitoring, 2 consecutive seated measurements, at least 1 minute apart, recorded twice a day for at least 4 days, preferably for a week, and measurements first day discarded, average all values after that for home blood pressure monitoring, which is an alternative to automated ambulatory blood pressure monitoring. They offer antihypertensive treatment to patients who have stage 1 hypertension or age under 80 and meet the defined criteria, or have stage 2 hypertension any age. And if age 40 or under with stage 1, with or without evidence of target organ damage, consider special evaluation of secondary causes or further assessment of potential target organ damage. So these are in their new guidelines. Monitoring. Clinic blood pressure to monitor response, aim for target blood pressures less than 140/90 for people under age 80 and 150/90 age 80 and over. And again, the evidence based on the high vet is to get your systolic less than 150. We don't have good data dropping it lower in that population because high vet was 80 to over 100 years of age. For people identified as having white coat effect, consider ambulatory or home blood pressure as adjunct to clinic blood pressure, and aim for home or ambulatory monitoring below 135/85 for people under age 80, so it's 5 millimeters lower than in-office blood pressure goal, and if you're 80 or over, 145/85, again, 5 millimeters lower than the 140/90 or 150/90. And their care pathway that's looking at, again, greater than 140/90 is confirmed, and that's your clinic blood pressure. Ambulatory or home is greater than 135/85, stage 1 hypertension. Stage 2 is the same as we've had, greater than 160/100, and if it's ambulatory or home, it's greater than 150/95 is what they've defined it as. And if target organ damage is present or a 10-year risk is greater than 20%, they offer antihypertensive treatment in addition to lifestyle. And the antihypertensive treatment is pretty simple. Age 55 or under, they start with an ACE or an ARB if they're ACE intolerant. If they're over 55 or a black person of African or Caribbean or family origin, they start with a calcium channel blocker, a C. If you're not at goal or step 1 in either of those, you add the other of those. They don't use a diuretic as step 2 in this new guideline. If you start with an ACE, you add a CCB. If you start with a CCB, you add an ACE. Step 3 is add a diuretic in their guideline, and it's only chlorothalidone or indapamide are preferred. Chlorothalidone 12.5 to 25, indapamide 2.5 milligrams. And if you're still not at goal, consider further diuretic, low-dose spironolactone 25 milligrams, or an alpha or beta blocker. So their step 4 ideally be spironolactone. And again, I think we may see that in our new guidelines in the U.S. as well. These are the current UK guidelines just published in August of 2011. So they beat out the JNC 8 as far as being published. Now, one of the issues that is brought up with NICE that, again, I'm not sure it's going to show up in JNC 8 is related to ambulatory blood pressure monitoring. And if you look, there are people who have hypertension, and we don't pick it up in the office, but most of us, if we're normal, will drop our blood pressure at night while we're sleeping. The people who don't drop their blood pressure, some actually increase their pressure at night, called non-dippers, appear to have increased cardiovascular risk, increased risk of progression of end-stage renal disease based on some data with valsartan with evening dosing. So we've got some data, dipper versus non-dipper. This is the dipper slide, and this is what you'd like to be if you had your druthers. In other words, when you go to bed, your blood pressure, systolic and diastolic, drops. So you see a drop, and then it comes back up in the morning. This is the typical patient who's a dipper. This is a non-dipper, and these are people who appear to be at increased risk of cardiovascular events. So you can see their blood pressure goes up while they're sleeping and then drops in the morning hours after awakening and comes back down during the daytime. So we've got some data that patients, non-dipping is common in people on high sodium diets, people with diabetes, heart failure, resistant hypertension, obstructive sleep apnea, hypertensive advanced stage, and renal disease appear to increase your risk of being a non-dipper. Non-dippers increase mean blood pressure, higher blood pressure at night. And you won't pick that up for most of them unless you do an ambulatory blood pressure monitoring. Increased risk of target organ damage, cardiovascular morbidity, mortality, and total death. And this is actually discussed in JNC7. It's actually in JNC7. Now, this is a trial that's designed to look at it. This is called MAPEC, and most of us have not heard of it. The journal is Chronobiology International, October of last year. It's 2,156 hypertensives, equally split, men versus women. Mean age is 55. Randomized to ingest all their prescribed blood pressure meds once a day in the morning versus a morning, at least one at bedtime, one or more at bedtime. Baseline blood pressure was measured at 20-minute intervals for 48 hours every year in this trial. So they did ambulatory blood pressure monitoring for 2 consecutive days, 48 hours. And despite lack of differences in ambulatory baseline, those who had at least one drug at bedtime had significantly lower sleep time blood pressure, higher sleep time relative decline, and they switched from non-dipper to being a dipper. So non-dipping 34% in the group that got bedtime dosing versus 62% those who got it in the morning. Higher prevalence of control of blood pressure, mean blood pressure. And this is what happened to events. This is event-free survival rate. Tremendous difference, and the average follow-up is 5.6 years. So this is 5+ year worth of data. And if you break it down, here's your individual events with blood pressure, bedtime, at least one drug versus all in the morning. So total events, total death, cardiovascular death, stroke, cardiovascular events, MI, angina, heart failure, renal artery occlusion, all statistically lower with a group that had at least one drug at bedtime. And it doesn't cost you anything. And here's your numbers needed to treat. If you look at death, for every 67 patients treated for 5.6 years, one less death. Cardiovascular event, number needed to treat is 9. 11% absolute risk reduction greater if you took one medication at bedtime or more versus all in the morning. And it doesn't cost you anything except remember to take one drug at bedtime. Interesting data. So their conclusions, these are not mine, bedtime chronotherapy with one or more blood pressure meds compared to conventional upon waking treatment with all meds more effectively improves blood pressure control, better decrease the prevalence of non-dipping, and most importantly, significantly reduce cardiovascular morbidity and mortality. The same group, 2 weeks ago, published the data in the Journal of the American Society of Nephrology. Jason, bedtime dosing, 661 patients with chronic kidney disease, followed for, again, 5.6 years average. So it might have been a subset of the original trial. I don't know for sure. But look at the outcomes. At 5.4 years, 1/3 the cardiovascular risk. So 69% reduction in cardiovascular events. Bedtime dosing, when they composite cardiovascular disease outcome included only death, MI, and stroke, 72% lower event rate, and patients' ambulatory control, 56% versus 45%. This is brand new, just published in the last 2 weeks. From the same group, the data is from Spain. This group is a Spanish group. Wish we had better data, and I wish we had a trial underway in the US right now to answer this question. We don't have anything that I'm aware of designed on the books to answer this question. I've given this data to the people involved in JNC8. I've actually sent copies of it because they weren't planning to evaluate it, from what I was told. And I hope they'll at least mention it, because if we look at it, controlling blood pressure is the most important things we can do to reduce events. And maybe if we use a bedtime dose of our ACE or ARB, and if you don't realize it, the HOPE trial dosed ramipril at bedtime, not in the morning. But the New England Journal publication doesn't tell you that. Doesn't say when they dosed it. The trendapine in the Sisture trial was dosed at bedtime, not in the morning. This data is the only trial I'm aware of to compare morning versus evening dosing. We don't have the information, but I think it's good food for thought, and it makes sense. And if you have the availability to do home blood pressure monitoring, then it might be worth looking at and considering an evening dose for patients who do not get the typical dipping pattern, and especially if it's an ACE or the ARB. Amlodipine got a 30 to 50 hour half-life. Not a big deal. Chlorothalidone got a half-life of 30 to 40 hours. Not a big deal. But hydrochlorothiazide, ACE inhibitors, ARBs, a lot of the drugs we have don't have half-lives to give us the same level of control for 24 hours and may affect that dipping versus non-dipping pattern. Food for thought. Not saying I have the answer, just suggesting it's something we need to look at and consider. We might be able to reduce residual risk tremendously, because these are significant reductions over and above treating blood pressure, because all these patients had their blood pressure treated in these two data sets. And there's a much greater reduction if they took at least one drug at bedtime. Food for thought. Quickly, we still got a little bit of time. I want to finish up with some stuff on diabetes. The ADA guidelines that we have, Dr. John Buse at UNC, Chapel Hill, is one of the authors, former president of the ADA, but they're evidence-based, and these were updated in 2009. And they suggest first line to add it to lifestyle is metformin. It's the only drug we have that has really good morbidity and mortality data for type 2 diabetes. If you're not at goal, add either basal insulin, NPH, insulin glargine, insulin detamir, one of the long-acting insulins, or add one of two sulfonylureas, glipizide or glimepiride, not glyburide. We'll come back to that in a minute. If you're still not at goal, lifestyle plus metformin plus intensive insulin. They don't stop the insulin when they add, or don't stop the metformin when they add intensive insulin in the ADA algorithm. And I'll show you why in a minute. It's not something we're used to doing, but it's something we need to think about. Less evidence-based, tier 2, you could add pioglitazone, and they talk about the fracture risk, talk about the heart failure risk, talk about the edema risk, don't talk about macular edema, don't talk about the bladder risk, cancer risk. That was before, so those are not in there. Or exenatide Byetta, a GLP-1 analog, is also an option. Other than that, there's no other drug listed in the ADA evidence-based algorithm. There's no DP4 inhibitors. They're not there because there's no evidence for them. So that's the ADA. This is the reason for gliburide's gone. This was published last year, November 2010. And what it looks at is mortality in patients with diabetes treated with glibenclamide, which is glyburide in Europe, as compared to glipizide or gliclazide and glimepiride. And you can see in every case, mortality is lower with glipizide or glimepiride than glyburide. Glyburide causes the most weight gain, the most risk of hypoglycemia, has an active metabolite, it's renally eliminated, and it's no longer recommended in the ADA algorithm. Glyburide is the #1 prescribed oral sulfonylurea, and it shouldn't be used. Glipizide, the old glucotrol XL, is generic. Glimepiride, the old Amaryl, is generic. Those are the two that are in the algorithm. The others are gone. So that's why I wanted to point that data out, because this is total mortality. This is why we add metformin and insulin. This is a trial published in Archives of Internal Medicine back in 2009, and it's called the HOME trial. And it's 390 patients who are on intensive insulin, and they decide to either add placebo or metformin back to their intensive insulin. This includes people on 4 doses a day. like insulin glargine, once-a-day basal, plus 3 doses of insulin aspart or 3 doses of insulin lispro added to it. And what you see here is at the end of 4.3 years, either metformin or placebo added. And this study, these are the bottom lines. Treatment-prevented weight gain, the mean weight loss was 3.07 kilograms over that 4.3 years. So they actually were able to lose weight when they added metformin back to intensive insulin. Improved glycemic control. The A1C level was 0.4% lower in the group that had metformin added back to versus insulin alone. So insulin plus metformin was beneficial. Insulin requirements reduced an average of 19.6 units a day. May be one of the reasons for the weight loss. Able to reduce insulin dose and still maintain or improve your A1C. And secondary macrovascular endpoints, 39% relative risk reduction. Cardiovascular events, stroke and MI significantly reduced at 4.3 years when they added metformin to insulin versus insulin alone. No downside at all. Generic metformin is cheap, doesn't cost hardly anything, and it is in the guideline as a recommended drug to continue when you go to intensive insulin. And this data suggests it reduces morbidity and mortality. As far as macrovascular events, number one thing that kills people with type 2 diabetes. Number needed to treat, prevent one macrovascular event was 16.1. So number needed to treat at 4.3 years of 16 if I add metformin versus insulin alone. And if you live long enough with type 2 diabetes, you're going to need insulin. And over time, you're probably going to need intensive insulin, not just basal insulin. These are type 2s. These are type 2s who are being treated with intensive insulin, and they're still treated with insulin, but you either add metformin or placebo to the insulin. That's what they did in this trial. Nobody's talking about it, but it's there, and it's the reason the guidelines recommend continuing metformin with intensive insulin. And most of us are not aware of it because we haven't been told about it. It's not something we're aware of. Now, metformin still's got a box warning, and I've put it up here. Avoid in patient renal dysfunction. Male serum creatinine greater than or equal to 1.5, females greater than or equal to 1.4. It's not based on any evidence, but it's been in the label from day one, 30 years. And it's there based on the old metformin predecessor, fenformin or DBI, that came and went due to lactic acidosis. That's why it's there, but it's not based on any evidence. Come back to that in a minute. Heart failure used to be a contraindication. It's no longer a contraindication. In fact, the ADA standards say metformin may be used in patients with stable heart failure if renal function is normal, avoided in unstable or hospitalized patients, but can be used in patients with heart failure. It's been shown to reduce macrovascular events if you have diabetes and heart failure. So we've moved from a contraindication to potential indication for the drug. Now, our friends at the Cochrane database, the evidence-based folks, a year ago did a meta-analysis of all the data on lactic acidosis metformin. They looked at 347 comparative trials, over 70,000 patient years and 55,000 patients. And basically, the incidence of lactic acidosis per 100,000 patient years was 4.3 cases of metformin, 5.4 in the non-metformin group. No difference. So we haven't seen an increase in lactic acidosis in any trial used metformin for type 2 diabetes. No difference in lactate levels, either as mean treatment or a net change with metformin compared to not metformins. And they say no evidence, prospective comparative trials, observational studies, metformin associated increased risk of lactic acidosis. That was published last year. Here's a trial from 2002 that looked at patients who had serum creatinines up to 2.5. And they measured lactic acid levels. No increase in lactic acid levels with serum creatinines up 2.5. This was from Diabetes Care, June of this year. And it's a call for the US and the ADA to follow what the UK, Canada, and Australia have already done. These are the recommendations and the labeling in the UK, Canada, and Australia. If your estimated GFR is greater than 60, no contraindication, you can go to full dose of metformin, 2 to 2.55 grams a day. If it's greater than 45 but less than 60, continue use, monitor every 3 to 6 months, renal function. 45 to greater than 30, prescribe with caution and drop your dose to 1/2 max, so a gram a day. They don't stop the drug until your estimated GFR is less than 30. And that's significantly higher than a serum creatinine of 1.4 or 1.5. So the rest of the world is saying, wait a minute, guys, we ought to be using metformin in these patients, and we're being inhibited from using it based on our current label. So they've asked the ADA and they'll ask the FDA to review this information. No company is going to be involved in this. So that's from Diabetes Care, June of this year. Let me finish up briefly with linagliptin, Tradjenta, the newest DP4 inhibitor. This one is a meta-analysis presented at the ADA this June the 26th, at the late-breaking trials. It's a meta-analysis of over 5,200 patients in their database in all the trials to get this drug approved, okay, versus whatever the comparators are. And the comparator mainly is glimepiride, and Vigibose is a alpha-glucosidase inhibitor we don't use, like Precos, Miglatol, Glycet, those kind of drugs we don't use very often, mainly used in Japan. And what they looked at was, if you look at the linagliptin primary endpoint, 0.3% cardiovascular endpoint in their meta-analysis in over 3,300 patients, comparators 1.2%. So they show a 66% relative risk reduction with linagliptin versus comparator. And if you break it down to individual components, cardiovascular death, stroke, or MI, significantly lower. All adjudicated cardiovascular events, lower. FDA custom MACE events, significantly lower. Everything tends to be lower with linagliptin versus placebo or comparator. The problem we have is we need a controlled trial, and they're doing one, but it's just getting started. So we're at least 5 years away from having data with exenatide once a week, cardiovascular events, with Victoza, liraglutide, with the DP4 inhibitors. Those studies are just getting started. So right now, I'm not going to be able to tell you with any certainty there's going to be a reduction in events, but it looks promising based on the meta-analysis data. But there's a downside. This is from Gastroenterology in July of 2011, this summer. Came out of UCLA. Pancreatitis, pancreatic, and thyroid cancer with GLP-1 based therapies. This is not a controlled trial. The animal data suggests there might be an increased risk of pancreatitis, pancreatic cancer, and thyroid cancer with GLP-1 analogs, and maybe an increase in pancreatitis, pancreatic cancer with DP4 inhibitors. So those are things that companies are being required to study. So what these investigators did was look at the FDA database for exenatide and for sitagliptin Januvia, so Byetta and Januvia data. And here's what they found. Pancreatitis, exenatide, over a twofold relative risk increase compared to what they would expect with comparators. Pancreatitis, sitagliptin, twofold increase. Pancreatic cancer, exenatide, ninefold increase over what they expect with comparators. Pancreatic cancer, sitagliptin, is also slightly increased risk. Thyroid malignancy, exenatide, increased fourfold, and sitagliptin not significantly increased. All other cancers, no significant difference. And they put it on the odds are here in this table. And those are warnings in the labeling for the drugs. So again, I have no data they reduce events with any certainty. I know they lower A1C in the right direction, they're not magic. They cost a lot more than most of our other therapies that are evidence-based, and they have these red flags that we don't know what the answers are. So should we be going to GLP-1 analogs, DP4 inhibitors, when we've got good data with insulin and metformin to show reduced macrovascular events, which is what kills people with type 2 diabetes? Question that each of us has to answer. Where do we go? And why these guys are not evidence-based level 1 evidence in the ADA algorithm? Because there's some unknowns and we don't have long-term morbidity and mortality data. It's what we need to know. So having said that, I've still got about 10 minutes left, and I promised Dr. Basil I'd have time for questions. So let me open up wherever you want to go. And it doesn't have to be on cardiovascular stuff. There's lots of other drugs I normally cover at this meeting. Namenda? Namenda is an interesting drug that has got some limited data suggesting it slows progression of patients with Alzheimer's disease. But it really is not magic. It doesn't restore lost function. Best data is actually the combination of donepezil, Aricept in combination with Namenda. But again, it's not magic. And if you look at the absolute numbers, there's really not a whole lot of difference. They're statistically significant, but it's up to the caregiver, in my mind, whether they perceive enough benefit to continue the cost and the side effects, which are significant with these drugs. So I'm not a real big fan of using the cholinesterase inhibitors or Namenda. And if I'm using it, I'm going to probably try and start it earlier than later, because the best case scenario is slow down progression a little bit. But I'm really not going to restore cognition over time. What kind of benefit are they really going to get? And again, I think that's up to the caregiver to make that call, because the patient's not going to realize it one way or the other when you're starting these drugs. If the caregiver perceives a benefit, I'm not going to withhold it. If the caregiver says, I don't perceive any difference, I'm not going to let them be scared to stop the drug. Because sometimes they've been programmed, you can't stop the drug because they're really going to rapidly progress. That's not the evidence. So I don't hesitate to stop if they do have significant disease and there's no benefit of the drug, there's no reason to continue it. They're costly and they do have side effects. Yes? Yes. And I wish I had a good answer to that question. But I can tell you that from most drug standpoints, the data is with Cockcroft and Galt or measured creatinine clearance. The gold standard would still be measured creatinine clearance. And if you've got that, I'd go with that. That would be my one I would go with. Cockcroft-Galt, again, is a guesstimate, just like MDRD is. And there's some people saying that MDRD may not be the best guess for estimated GFR now. There's another equation that appears to produce a little better response. But again, they're not magic. And we haven't dosed drugs based on MDRD, estimated GFR, and we have based drugs based on Cockcroft-Galt, based on what the FDA's put in the label. Not based on serum creatinine. That metformin data is not based on any of those. It's a serum creatinine, which is notoriously probably the worst predictor of glomerular function in those patients as they get older. So I wouldn't use that at all personally. But I feel better with the MDRD or estimated GFR, but the best yet is a calculated or measured creatinine clearance would be my gold standard. Other questions? Yes? Yeah, Vibrid, Vilazodone. This is the newest antidepressant, and our friends at Forest are bringing it to you because they've lost the patent protection next year for Lexapro escitalopram. So they licensed the drug. They didn't do the studies to get the drug approved. They picked it up after the drug was already through the FDA review process. So they haven't been involved in any of the trials up till now. The trials are all short-term, and they're all placebo-controlled, and they all show better than placebo. But the mechanism of this drug is a little different. It's an SSRI, plus it also has serotonin receptor agonist-antagonist activity. So it's like Buspar, plus an SSRI. And what they're trying to do is make a connection, because the STAR-D augmentation trial done by the National Institute of Mental Health had 3 different augmentation arms. One of them was you could add buspirone to your citalopram. One of them you could add, actually 2 different arms, you could add bupropion to your SSRI citalopram. And in all cases, about 1 out of 4 patients responded when they added either Buspar or added bupropion to their citalopram if they hadn't responded to citalopram, which is the same as irregular STAR-D data. If they're on citalopram didn't respond, you could switch to sertraline, 1 out of 4 responded. You could switch to venlafaxine, an SNRI, 1 out of 4 responded. You could switch to bupropion, norepinephrine dopamine, 1 out of 4 responded. So we've got 5 different interventions that all show the same efficacy, none superior to the other. So they're making a stretch. They haven't done a study to look at resistant depression. All they have is placebo-controlled, and it looks the same as any of the other SSRIs. but there is no good data suggesting it's got a niche. It's got a $140 a month price tag where every other SSRI is generic except Lexapro that goes generic this coming year. So that's kind of where I see the drug right now. Yes?
I noticed that the vitamin B12, we're having a hard time getting injectable, and these people are suggesting nasal. The nasal spray is a substitute.
Yeah, you actually have lots of different ways you can get B12, and B12 injection is one of the drugs that is on short supply. It's back ordered, and part of the reason is a lot of the manufacturers have consolidated, and they're putting their more emphasis in producing drugs that have a higher return on investment. So it's one of the drugs we've had a chronic shortage of, and just like several of the chemo drugs that are generic now are in short supply, some of the injectable antibiotics are in short supply, and the FDA is trying to correct that right now. The president actually signed an executive order giving the FDA additional authority to try and prevent and minimize those shortages. So hopefully those will come back, but you do have various options, and if you develop a peripheral neuropathy due to B12 deficiency, from metformin, from the PPIs, those kind of things, you can probably give oral B12 with or without intrinsic factor. So there's lots of different ways you can give it, and the old red placebo injectable B12 is fine, but if you can't get it, oral is also good for most patients. You don't need the injectable for most patients. You've got the nasal, you've got the oral, lots of different ways you can give it. If you have somebody, the question is recommending checking B12s in patients in metformin. There's actually data out of the University of Texas, San Antonio, 2 years ago at the ADA. And these were a Mexican population, or Mexican Americans, and they looked at people with peripheral neuropathy and had been on metformin for 2 or more years, and were able to correlate those who had peripheral neuropathy were more likely to have low B12 levels on metformin. And in fact, if they had peripheral neuropathy, more than 70% of them had low B12 levels. Now, what they didn't do is tell you what happens if you correct the B12. They haven't done that, but when you think about it, metformin from day one, 30 years ago, its package insert says it induces B12 deficiency. Proton pump inhibitors induce B12 deficiency. So especially on a PPI and metformin, before you blame the neuropathy on diabetes, check a B12 level. And if it's low, it's potentially treatable, reversible neuropathy. You don't need to put them on a pregabalin or a gabapentin or a duloxetine, one of the drugs for diabetic peripheral neuropathy. It's potentially treatable, preventable. So if I've got somebody, new diagnosis of peripheral neuropathy, they have diabetes, I'm going to check a B12 level. It's not expensive, it's easy to do, and it's easy to treat. And before you put them on one of these expensive toxic regimens, think about B12.